Bismillahirrahmanirrahim. So today's lecture is on the topic glomerular diseases. Before we start the topic, let us see what is a normal glomerulus, what are the components, and then we'll move towards the injurious effect which lead to the damage of this glomerulus, and then we'll see what are the responses of the glomeruli to injurious stimuli, and then how the patient presents with glomerular injury. So first of all, in a normal glomerulus, we have the blood vessels. This is basically the outer wall of the glomerulus. It is lined by parietal epithelial cells. These are the parietal epithelial cells. Then we have this space. This space is basically Bowman's space or urinary space. Then we have these vessels and these visceral epithelial cells. Visceral epithelial cells are also known as podocytes. So if we really zoom into these cells, how do these cells look like? These are basically, if this cell is wrapping the blood vessel, then it has the foot processes which attach on the surface of the blood vessel, and these foot processes are separated from the endothelium via basement membrane, and this is the endothelial lining. So the filtration occurs in this place. Filtration occurs from here, and then the filtrate goes here, and then it goes into the tubules. In the middle portion of the glomerulus, there is sporting structure and certain cells. These cells are known as mesangial cells. And few inflammatory cells are also present in this region. So what are the main components? A quick review. First of all, parietal epithelial cells, then Bowman's space, then visceral epithelial cells or podocytes, basement membrane, endothelium, and sporting structures, mesangial cells, and lymphocytes or inflammatory cells. So this is basically the normal structure. What are the effects that can hit and damage all these structures? So there are three main mechanisms you should remember, the most important being immune. Why immune? Because immune processes usually lead to production of antibodies, and antibodies circulate in the blood. So those antibodies are carried via blood into these capillary loops, and these antibodies come in contact with the vital structures of the glomerulus. So immune mechanism is the most important mechanism that leads to glomerular injury. As we studied previously in the pyelonephritis, infections were the most common etiological factor. Why so? Because infections usually ascend from the lower urinary tract, and in the ascent they have to go through the pelvic ileal system. Therefore, that portion of the kidney is affected first. While in circulatory antibody mediated mechanisms, these capillaries are the first structures to come in contact with the antibodies. Therefore, the damage occurs in the cortical region or the glomeruli of the kidney. So these are the core concepts. Normal structure. Now what are the damaging effects? The most important being immune. Then other mechanisms are cell-mediated injury and complement-mediated injury. So, having said that, let us focus on the first mechanism, that is immune-mediated mechanism. Immune mechanism involves few processes which lead to glomerular damage. The first mechanism is antibodies which are produced against antigens which were present within the glomeruli. For example, if this is the kidney, so these are basically the glomeruli which are present in the cortex of the kidney, and the antigens which reside within these glomeruli. When antibodies are produced, these antigens So this is one form, antibodies against antigens within glomeruli. Then second form is antigens were not a part of the normal structure of the glomeruli, but they were planted there. How can then that happen? For example, in post-streptococcal glomerulonephritis, the streptococcal exotoxin B, it is deposited via blood into the glomerular basement membrane in the subendothelial and subepithelial spaces. So that antigen binds with the circulating antibodies and leads to glomerular damage. So that is another example. Antibodies against antigen within the glomeruli. An example of this is Goodpasture syndrome. And when exogenous antigens are implanted in the glomeruli, we have a very important example. This is post-streptococcal glomerulonephritis. Then the third mechanism is basically, let's write over here. Third mechanism is immune complexes were already formed in the circulation, and they could not pass through the basement membrane of the glomeruli, so they started depositing in this situation. Circulating immune complexes started depositing in the glomeruli. So what is the example of circulating immune complexes which deposit in the glomeruli? The most important being SLE. So these are the main immunological mechanism. A quick revision: antigens which are endogenous to the glomeruli, such as basement membrane of the glomeruli. When antibodies are produced, those antigens in certain human beings, then that leads to Goodpasture syndrome or glomerulonephritis. Then a patient had an infection and infectious agents antigen were deposited in the glomeruli, which led to damage of the glomeruli, and this was another example. And this was another disorder, and the main example was post-streptococcal glomerulonephritis. Third mechanism was immune complexes were already formed in the circulation and they could not pass through the basement membrane of the glomeruli, and they deposited there and started causing damage. And the main example of this is SLE. So these are three main mechanisms. Any wise student can ask, how can these antigen-antibody complexes lead to damage of the glomeruli? The answer lies in when these deposits are when these deposits settle down in the glomeruli or they bind to the glomeruli, they lead to activation of certain factors. For example, they recruit neutrophils, and neutrophils produce oxidases and enzymes which lead to cell damage. Secondarily, these deposits activate complement system. Complement system produces C5a, which helps recruit neutrophils. Secondarily, it forms membrane attack complex C5 to C6, and this lead to lysis of the cells in the glomeruli. This was the main mechanism of the glomerular injury. A quick review. First of all, we studied what was the normal structure of the glomerulus. There were few main components. You should remember what are the visceral epithelial cells. You should remember what is the basement membrane, between which two structures does the basement reside, and that is between the endothelial cells and the visceral epithelial cells. Then we came towards the mechanism of the glomerular injury. There were three main mechanisms, and the most important mechanism is immune mediated. Immune mediated has three subcategories. First one, antigens within the glomerulus, and antibodies, circulating antibodies bind to that antigen. Then second mechanism, exogenous antigen was deposited on the glomeruli, and then antibodies bind to that. Third was circulating immune complexes started depositing in the glomeruli, and this was the mechanism which led to the glomerular damage. That is, all those complexes activated complement system, which produced two main factors, C5a and membrane attack complex. C5a recruited the neutrophils and it produced enzymes and led to the damage of the epithelial cells. Now, after all that injurious stimuli, our sad-looking glomerulus has to respond in some way. So, the main mechanism through which glomerulus responds is it will start producing extra amounts of the normal structures that it already had. For example, it had mesangial cells and few inflammatory cells. So, it will result in increase in number of these cells as well as endothelial cells and visceral epithelial cells. So, a combination of increase in number of visceral epithelial cells, endothelial cells, and mesangial cells is basically hypercellularity. So this is basically a response mechanism of the glomerulus to the injurious stimuli. That is, it cannot understand what is going on, so it results in increase in production of normal constituents of the glomerulus. That is, increase in visceral epithelial cell, endothelial cell, mesangial cells, resulting in overall hypercellularity of the glomerulus. This hypercellularity, when it becomes chronic, then these increased number of visceral epithelial cells stimulate the production of collagen matrix in this urinary space. And this results in the formation of specific structure that looks like our half moon or crescent. So what is a crescent? Crescent is basically the chronic state of this hypercellularity, and it comprises of these increased number of visceral epithelial cells, plus main is fibrinous and collagenous matrix in the background. Along with these mesangial and inflammatory cells. When the injurious stimuli is very severe, then all this process happens very fast, and all you can see between the time duration of presentation of the patient and renal biopsy is you see the crescents. And one of the example of this condition is RPGN, or rapidly progressive glomerulonephritis. It is a medical emergency. And one of the entity that falls in this heading is Goodpasture syndrome. So usually in the patient with Goodpasture syndrome, when the antibody binds to the basement membrane, the change is initially diffuse because it will bind to the basement membrane antigen of almost all the glomeruli. So all the glomeruli will show hypercellularity initially, but by the time this process goes very fast. By the time the patient presents, we start seeing the later stage of the hypercellularity, and these are the crescents within the glomeruli. When we see crescents along with the clinical picture of acute renal failure, that is a medical emergency, and patient is treated with immunosuppressants. Now we come to the second response of the glomerulus, and that is increase in the thickness of the basement membrane. Say for example, if this is the glomerulus, when something injurious hits the glomerulus, it thinks that maybe I'm not doing the filtration right, so the main barrier is basement membrane. It should be thickened so that filtration should remain at its place. And in order to do so, it undergoes three main changes, and that is increase in this process basically involves three main processes, and first of all, there is increase in synthesis of collagen. Second is deposition of plasma proteins, And third factor was deposition of those immune complexes also led to increase in thickness of basement membrane. So first response was it started increasing its hosts, that is the cells. Then these cells started going at one place and resulted in formation of crescent. When this could not help, then it started thickening its basement membrane, maybe in the hopes that it might restore filtration, but that effort is futile, obviously, because once the basement membrane becomes thickened, it is also weakened and interrupted at places due to inflammatory processes. So we get all those features of hematuria and proteinuria. So now the third change is halitosis. What is halitosis? It is the deposition of plasma proteins in the extracellular position within the glomeruli. Once the damaging effect damages the basement membrane, the filtration process is altered, and then the plasma proteins start depositing within the glomeruli. These can deposit within the endothelium, in the subendothelium space, or on the basement membrane, or within the mesangial matrix, and these look like amorphous pink deposits on H&E. These are basically plasma proteins, and these lie outside the cell, that is, these are extracellular. This condition, this change is seen in very specific entities, and one of the main examples is diabetes mellitus, in which halitosis is seen. Then we have fourth change, which is the last change, and this is sclerosis. Sclerosis is fibrosis of the glomerulus, and as I have already told you, all the chronic inflammation or all the inflammatory processes, they end up in fibrosis and loss of neutrophils and replacement by lymphocytes. So if this is the glomerulus, wherever the inflammation was, those these small capillary loops, they get destroyed, and these areas are replaced by fibrosis, which also looks like pink deposits, let's say on H&D. So now sclerosis looks pink on H&D. Halitosis also looks pink on H&D. One is the end stage and one is not yet end stage. How can we differentiate between these two conditions? The answer lies in the special stains. These are basically made up of collagen. So collagen stains with a trichrome stain, while halitosis is due to plasma proteins, and this stain will be negative, as this stain only highlights collagen bundles. So these are basically the main four response mechanisms of the glomeruli: hypercellularity, basement membrane thickening, halitosis, and sclerosis. So now first was the various mechanisms which led to the damaging effect on the glomeruli. Then the glomerulus responded in certain ways. Now patient has to manifest in certain way when the glomeruli are undergoing damage, and these changes are variable. One change is nephrotic syndrome, or let's say this is the clinical presentation. Then second can be nephritic syndrome. Third is ARF. Fourth is chronic renal failure. Fifth is end stage renal disease. So nephrotic syndrome. Nephrotic syndrome has certain factors that need to be met in order to make the diagnosis of nephrotic syndrome, and the main factor is proteinuria. It needs to be more than 3.5 mg per deciliter. And why does proteinuria occurs? Basically, when the glomeruli are undergoing damage, this basement membrane or the filtration barrier undergoes damage, and the plasma protein, they start passing from the blood into the urinary space. So this leads to loss of plasma proteins within the urine and hence proteinuria. And the patient will present this proteinuria. What will it look like in patient's urine? It will lead to the production of frothy urine. So when you have a clinical scenario that has frothy urine word in it, so that means the patient is having proteinuria. Second change is basically hypoproteinemia or hypoalbuminemia. Hypoproteinemia, and this is very understandable because patient is losing all the plasma proteins in the urine, so the plasma protein level within the blood will fall. This will lead to decrease in osmotic pressure within the blood and fluid retention within the tissue. Now the third manifestation of nephrotic syndrome is hypercholesterolemia, hyperlipidemia. This increase in lipid levels within the blood are basically because of increase in the level of lipoproteins within the blood. When the protein is lost from the glomeruli, liver in turn comes for the help and starts producing increased amount of lipoproteins. These lipoproteins bind with the triglycerides and then they are transported within the blood. So increased lipid content leads to increase in the lipiduria, which is the fourth manifestation of nephrotic syndrome. So these are the key features when a patient presents to you with in OPD or in emergency. You run some basic labs, that is RFTs, urine complete, etc., and you categorize patient in these categories, whether the patient has nephrotic syndrome, nephritic syndrome, ARF, CRF, and end-stage renal disease. This helps you narrow down the differential diagnosis. There are certain diseases which fall in the category of nephrotic syndrome. For example, if the patient is young, usually between 3 to 6 years of age, and has nephrotic syndrome, the first differential that should come in your mind is minimal change disease. And then if the patient is middle-aged and presents with proteinuria, then you have a vast differential. It can be membranous glomerulonephritis, it can be FSGS, it can be, there are numerous disorders that come in this category in the middle age group. Then nephritic syndrome, this is relatively easier because three main categories fall in this group. First one is post-streptococcal glomerulonephritis. Second one is RPGN or rapidly progressive glomerulonephritis. And then the third one is good pastures falls within rapidly progressive, and then there is IgA nephropathy. So nephritic के तीन ही main differential हैं, and the features of nephritic are increase in the number of RBCs within the urine. Proteinuria is relatively less, and it is less than 3.5 mg per deciliter. And azotemia. Azotemia is basically decrease in the quantity of urine. So these are the key manifestation. If the patient on the lab investigation has proteinuria and all these findings, then you remove the categories of post-streptococcal glomerulonephritis, RPGN, and IgA from your differentials. When patient has nephritic syndrome, then you remove all the diseases which fall in this group and only focus on the diseases which lead to nephritic syndrome, such as post-streptococcal SLE. SLE is one of the very important diseases which usually lead to hematuria first. Now ARF. ARF is acute renal failure, and acute renal failure is usually manifested as oligo or anuria. And there is marked increase in serum creatinine level and decrease in GFR. Chronic renal failure. Chronic renal failure has a characteristic criteria for diagnosis. So the main diagnosis depends upon the GFR. If the GFR falls below GFR is less than 60 ml per minute per 1.73 millimeter square, and this condition lasts for more than 3 months. Then the patient is diagnosed as a case of chronic renal failure, or the patient has persistent albuminuria. End stage renal disease is when GFR is less than 5%. That is, kidneys are not working, more than 90% of the kidney function is lost. Then the patient is diagnosed as a case of end stage renal disease. And histologically, the diagnostic criteria is when there are less than 10% glomeruli present, or loss of more than 90% of glomes. So these are basically key clinical manifestations which happen whenever there is glomerular damage. That's all for now. Now we'll move towards post-streptococcal glomerulonephritis.